Call this meeting to order. This is Pediatric Subcommittee meeting for GETAC. We'll run through our roll call. So I'm Charles Macias. I chair the Pediatric Subcommittee. Britt DeVillier. Here. Can I have your attention, please? Can I ask you if you are going to join us, please join us. If not, please take a seat. Thank you. Justin Hensley. Here. Bonnie Hartstein will not be here. Charles Jaquith. Here. Juan Juarez has taken a new position with a different institutional affiliation, has resigned from the committee. Diana Kraus. Yep. Julie Lewis.
Present.
Jorge Saenz will not be joining us today. Last minute staffing issues. And Sally Snow.
Here.
And Vern Walker.
Here.
All right, so first order of business, just to mention that we have, as I mentioned earlier, Dr. Juarez will no longer be on the committee. We have 3 other members who are rotating off the committee. Dr. Saenz, who, as I also mentioned, is not here today. But we have 2 others who are also rotating off the committee that we want to thank for their continued service, and that is Justin Hensley.
Rotating off.
And Britt DeVillier. Okay, so committee liaison reports. We do ask that you give us just a brief description of the discussions that have occurred previous to this meeting. We recognize that there are, that we're the second meeting, so pretty much everyone will be meeting after this session. So we start with Air Medical. We'll defer that with Jorge. My understanding from him was that there were no pediatric issues to report. EMS, Vern?
I was absent in August, and they meet tomorrow, so I will be there. I'm not sure who attended in August.
Charles, Education?
They meet tomorrow. They did not have a in-between meeting this time, and I'll be able to meet tomorrow.
Diana, Injury Prevention?
They meet tomorrow as well.
Are we aware of any pediatric issues on their agenda?
No.
Medical Directors was Juan's. Julie Lewis, Stroke. Any pediatric issues?
No pediatric issues, but they will be talking about the 4 hours recertification for EMS that's going to be stroke content. It's not going to be an additional amount of hours for recertification. It's going to be included in what was content, so the regular course content. And then just some recommendations and updates that they'll be talking about today at their 2:30 meeting.
Okay. Thank you. Trauma Systems, Sally?
There were no pediatric issues discussed at last meeting, and they meet on Monday afternoon at 3:30, and we anticipate there'll be some discussion that has effect on pediatrics when they talk about their strategic plan for EMS and trauma systems.
And the RACs, Britt?
The RAC chairs had some interesting discussions. The biggest thing in regards to pediatrics are 2. One is the SANE designation and the SANE listing on the DISH's website that's being required by current regulations and guidelines. And there was definitely some discussion about the listings and how those listings will occur, and especially in the relationship to the pediatric facilities that have SANE programs, and how to direct the patients who have, this is so that patients can actually look up on the website where to go. And from my understanding, which I've kind of fallen off the email list somehow, that list is being generated and should be talked about at the meeting this coming Sunday night at the RAC chairs. The other discussion item for pediatrics, which they had requested that this committee vetted out, but I know there's some other issues that have precluded that, is the perinatal designation that is coming about also via recent regulation and state guidelines for dishes. And I'm sure this is, at this time, the main issue is whether or not the RACs will be the main framework or foundation for that versus the public health regions. And I'm sure those who are involved in that subcommittee via dishes and the RACs will have a further discussion on that again this coming Sunday night.
Great, thank you. Disaster planning was Bonnie's. I think we can roll some of the discussion over complex care registries into our state partnership discussion because we actually have a presentation related to that. And that was one of the agenda items that Bonnie had been following up on. All right, so that puts us on agenda item 1 and 2, identify and list the accomplishments of the committee. We'll take that at the end. And I'm not certain if this was one of your agenda items, which was Ebola recommendations provided by the CDC. To everyone's. Was there a specific item that we needed to address related to?
I will get back to you. I'll get calling her.
Okay. Great, thank you. So that puts us at update on child fatality review teams. As you might remember from previous meetings, Susan Rodriguez had provided that report. She's not been with the committee, but has now. We now have a liaison. Would you introduce yourself, please?
Sure. Hi, my name is Amy Bailey, and I'm the new State Child Fatality Review Team Coordinator. And I just have a few updates on our child fatality review. First off, we're going to be forming a drowning prevention work group. This work group is going to meet over an 8-week period, and we'll be developing a comprehensive data set of drowning deaths, discussing current prevention activities that are occurring in Texas regarding drowning. We will be looking at identifying evidence-based drowning prevention strategies and basically creating a drowning prevention action plan to go from there. And my second update is the Prevent Child Abuse Texas Conference. This conference is going to be February 22nd through 24th in Irving, Texas. And the Child Fatality Review will have a track on this conference again. And some of the topics that we will be presenting on include prevention initiatives using data for child death review, predicting maltreatment, and the role of the medical examiner. So.
Thank you. A couple questions. So with the drowning prevention work group and the comprehensive data set that was created, so we've had, I think over the course of the last 2 years, as we were working with the trauma registry and giving feedback, that was really one of our pain points, was that we felt the prior trauma registry didn't comprehensively integrate the needs of submersion injuries or drowning injuries. How will this data set tie into the trauma registry? Are these?
Right. We're going to have a representative from the trauma registry on this work group, and so we're hoping that it's going to kind of be a comprehensive data set of the trauma registry and child fatality review and data from different sources so that we can get a complete picture of what's going on in Texas.
Okay, and then how open will that be for users to access if members had a particular project that they wanted to look at?
Right. I'm not sure we've established that quite yet. The work group actually starts December 2nd, so I'm more than happy to update you when we start meeting on the different parameters and what we find, and so.
I have a question.
Sorry.
So are you saying that the submersion data will be incorporated into the state trauma registry?
The submersion data as far as from the trauma registry, or what submersion?
Whatever is collected, because right now there are two different registries. We can't look at submersion data if we look at the trauma registry. So will those be merged?
That is something that, again, I'm not sure. We'll start on December 2nd, and kind of we're going to be working out the logistics then on what we can do and what permissions that we need to merge any data between the different organizations and things like that.
So I would make a recommendation.
Sure.
Particularly with a center that's having to do the two, we collect all the drowning, submersion stuff.
Mm-hmm.
It would be much more proactive and more resource rich if we could incorporate it into the data set for the trauma registry. Just for the simple fact that then you have one-stop shop and you can utilize your same staff, and it will actually give us a better picture when we're looking at injury prevention activities by just going to one trauma to the state trauma registry.
Sure, I will definitely add that to the agenda.
This is great. We have been looking for strategies to push the submersion or the drowning injury agenda, and so this is wonderful to see that you're moving this with a specific focus for the group. So
Great.
Anything that we can do. We have invited the Child Fatality Review Team representatives to present at every meeting. We want to stay connected. We also want to know what we can do to help support that.
Great.
So if there are particular things that you need that your group needs from us to be able to disseminate or recommend activities through GETAC, please let us know.
I will. Thank you so much.
Thanks. All right, our next agenda item is update on rules revision. We had said that we would defer that to February with a plan, an implementation strategy to be discussed today. As you remember, we have a position paper on minimizing CT radiation. Unfortunately, both of our presenters, Juan and Jorge, are not here today. So by default, we will push that completely into the February agenda, and we will assign 2 new members to that. Okay, next item, Pediatric Facility Recognition Program. Sally?
Well, the Pediatric Recognition Program work team of the EMSC State Partnership Grant has had a couple of conversations. We had a webinar in April. Hopefully many of you were able to see, and if not, you can access that webinar on the EMSC website. Discussing kind of preliminary information about a facility recognition program, what that might look like in Texas and what it looks like in other states. We know that it takes time to implement. In fact, yesterday Sam shared with us on our conference call that the state of Illinois took 6 years from the time they actually had a working plan to actually be able to implement the program in their state. There are multiple states in the country who have facility recognition programs. Many are mandatory and some are voluntary. So we'll keep you updated on how that work team progress goes. We have either gotten support or are seeking support from groups like the Texas Hospital Association, Texas ACEP, Texas ENA has signed on, the Children's Hospital Association of Texas, the Texas Pediatric Society. So looking for some support from big groups like that have an interest in pediatric emergency care in the state. And we'll keep you posted. Anything else I missed, Sam?
Sam, anything to add?
No, that sums it up pretty good.
Okay, great. So you're up next, Sam.
Good morning. How y'all doing? Anyway, if you remember back in the August GETAC meeting, I presented to you the Pediatric EMS Recognition Program. And I believe Dr. Macias disseminated that out to y'all electronically. I did receive some feedback on that, and I didn't know if anyone else had any feedback or comments on that program that they'd like to give to me. If you do, if you wouldn't mind just emailing that to me, it would probably be the easiest way. We have presented this not only to the Pediatric Committee, but to the EMS Committee and to the RAC chairs back in August. and the rack chairs have disseminated that out to a lot of their departments and their racks, and I have gotten several, actually numerous different EMS agencies calling me over the last couple of months who are already wanting to participate in this program. So that's...
You might want to, I'm not certain that all the audience members are
Oh, okay. Well,
aware
I'm
of
sorry.
that.
The EMS recognition program is basically it will recognize our EMS agencies in a tiered system, a three-tiered system of bronze, silver, and gold that will recognize the agencies for things such as having proper pediatric medical equipment that goes above and beyond what the state requires, and also having current pediatric protocols. That would be the bronze level. The silver level would be the departments participating in pediatric continuing education that goes above and beyond what the state requires. And then the gold level would be the EMS agency participating in pediatric specific community outreach initiatives, things such as car seat safety installation, bicycle helmet safety, that type of thing. And so these agencies will get recognized through getting a certificate from the EMS for Children state partnership, and they will also receive decals that they can place on their ambulances if they'd like. I don't have that copy here, but we do have a draft of that decal available, and it will be at our exhibit booth across the street once the exhibit hall opens. So you're all welcome to stop by and take a look at that. And that's kind of it in a nutshell.
I think the crux of it, because I think there have been several frequently asked questions, is that it is voluntary.
It is voluntary. It's strictly voluntary. It will not be mandated in any way, shape, or form.
And the level of tier is determined by what?
So each one, the bronze, silver, and so on. The bronze level, which is the education and protocols, that's basically a self-evaluation. Since we do have so many agencies within the state, it would be difficult for us to physically inspect every one of them. So it'll be kind of on an honor system. The agency will fill out an affidavit stating that they do carry the recommended equipment and have the current protocols. As you move up into the silver and gold levels, those systems where the education and the community outreach, then that will require an inspection. We are still kind of working through that. Hopefully we'd like to put that at the rack level. At this time, it would have to be volunteers from the rack that would volunteer to help us do those inspections. I am currently investigating potential grants to help maybe help offset some of the costs with that. So, are there any other questions regarding how that tiered system works?
Great. Let us know what we can do. If you could give me the most recent updates. I think you've had some edits to the prior document because we posted it almost 6 months ago.
Yeah, so I have incorporated the suggestions for revisions that I have received, and I will email those to you.
Great.
So, okay. So the next thing I have is we have a presentation from Sharon Evans from Cook Children's Hospitals to talk about a special needs assistant program that they have. So I'd like to introduce to you Ms. Sharon Evans.
Good morning. My name's Sharon Evans. I'm the Injury Prevention Coordinator at Cook Children's, and myself and Cameron Brown, who is a Fort Worth firefighter for 31 years and also our staff care chaplain at Cook, were asked to come and present how we have used the SNAP program at Cook Children's and how it's benefited us. We have a short DVD. Unfortunately, SNAP has a bad name, I guess, because when we say SNAP, everybody thinks of the food stamp program. But it is Special Needs Assistance Program and not food stamps. So this will give you a brief explanation, and then we can tell you more.
If you, a family member, or someone that you know has an age-related mental or physical special need that would hinder them from being able to evacuate their homes during an emergency, your local emergency management office would like you to consider registering for the free Special Needs Assistance Program known as SNAP. The information collected in the SNAP program database is used by emergency management professionals in developing disaster response and mitigation plans, and by emergency first responders such as police and fire departments. Your private information is kept confidential as allowed by law and will only be accessed by participating public entities and any other organization which you give permission. This program is not the federal government Supplemental Nutrition Assistance Program, also known as food stamps, nor is it a pre-disaster government evacuation registration. This SNAP program is a voluntary information database hosted by the Fort Worth Office of Emergency Management, a division of the Fort Worth Fire Department, used to help locate special need residents in the event of a disaster. When an emergency situation develops, it can strike very quickly. You may not receive adequate advance warnings of severe weather events, such as tornadoes or flash floods. Man-made or terrorist disasters happen without any warning. If you have a special need and you live in an area affected by a disaster, you may not be able to evacuate your home in time and be directly impacted by the event.
We need help. She's having problems breathing.
By registering in the Special Needs Assistance Program, predetermined emergency plans would be followed, and first responders will have important information about your special need and where you live. This knowledge could dramatically speed up rescue efforts.
911, what is your emergency?
If you live in Fort Worth, emergency 911 operators are currently able to relay important information about your special need to first responders, such as the police and fire departments, if you make an emergency call to 911. This life-saving information is invaluable to rescuers during a medical or fire emergency. The program is free, legitimate, and registration is very simple. You can register online by going to www.snap4u.org. You can call the Fort Worth Office of Emergency Management at 817-392-6144. Or you can send a postcard or letter with your name and phone number to the Office of Emergency Management, City Hall, 1000 Throckmorton, Fort Worth, Texas, 76102. And a staff member will contact you to help in your registration. You will be asked for your name, address, gender, age, weight, contact information, emergency contact, and what you consider your special need. Not sure if you have a special need? You should know that emergency management personnel do not define the meaning of a special need. Anyone who has a special condition that might require assistance in the event of emergency or disaster is considered special needs.
So this gives just a brief overview, but Cameron will come and talk about how it's helped from the fire EMS side, and then I can give you a little more information how it's helped us at Cook Children's. Cameron?
Good morning. With being a firefighter first responder for 31 years, I have certainly seen a number of cases where this would have been beneficial if we would have had the information. When a citizen calls 911, then we have mobile computers that are on our fire trucks. So the more information that we have, the more it's going to be beneficial for the citizen. For example, during the ice storms, earlier this year, there were 2 patients who were transported to Cook Children's. It was separate incidents because they were event dependent. They had not registered with the SNAP program. If they had registered with the SNAP program, then the Fort Worth Fire Department would have known that if they would have called 911, that they had no electricity. What we can do is we can work with Encore or other power companies and say, this is an emergent situation. Where does this household stand as far as getting their electricity cut back on? if they would have stated it's going to be an extended period of time, then what we could have done is we could have taken portable generators out there and given them some additional power. They could have bought some additional time for that. Also, that it is so very important that when we have that information, that if we have a fire, then if a person is bedridden, then we would know, it could come up on there that they reside in the southwest corner of this residence, and that there's a large storage of oxygen. So that would be able to help us to expedite going in and rescuing that person. It works very well, and we have a great collaboration here that's going on with Cook Children's, and I would like to invite Sharon to come forward to talk more about that.
From the hospital side, we've just noticed that especially the special needs patients are told you need to contact your electric company, let your utilities know if your child's vent dependent or special needs. In reality, the families aren't doing that. The other problem we encounter is that if they do call, they may just call their local fire station, which there's no way to really track that family. They have been told we'll put it on a sticky note on our bulletin board, but when they actually get a call to that house, who remembers? EMS has been very open in saying that they're not always thrilled to go on a PD call, and so having that information ahead of time that it is a PD patient and what their background is helps. Then within the hospital, it's been a great comfort to our staff, because oftentimes they will call and try to tell the fire department or electric companies, and we run into some HIPAA issues about giving out patient information, which they're doing it in the best interest of the patient. But now these families have a way that they can go, they call, they're signed up. When they have a need, then they have some prior contact. We're also hoping and are still working on having where the fire department, families will sign a consent where the fire department can actually go into their house and do a tour to see if there is hazards such as, exiting the house. Do they need smoke alarms, carbon monoxide, what kind of assistance that family needs. So hopefully we can prevent problems way before they come up. Questions?
So if you had to estimate what percent of the complex care patients you could, in your catchment area, you're able to capture, and I assume you could probably look at that based upon encounters with the hospital, what percentage would you say are registered in the SNAP program?
We just rolled this out September 1st within the hospital officially, where we have the brochures and the information, the staff has the information to tell the families, and they can't pull specifically from Cook, but there's been about a 60% increase in pediatric registrations. So I'm honestly, in a couple of months, going to estimate 25 to 30% of our families have been touched by this and are now signing up.
Have you considered linking this kind of strategy with chat initiatives through the Children's Hospital Association? I mean, it sounds like a wonderful program, and part of where all this discussion came from was the positive data that we were able to pull from the state for STEER registration, and this was the part that Dr. Hartstein was working on, trying to identify what those resources look like, but this looks like a very aggressive push, and that's nice.
Right, we're just, like I said, those families are so overwhelmed. Disaster and emergency preparedness is just the last thing on their mind, so we're trying to make it as easy as possible just to hand them something to say, go to this website. And we've had families that maybe we don't necessarily consider special needs, but they have a lot of children, limited resources, and they can still call and sign up. It's not just really related to what sometimes we would define as special needs.
There's a separate effort as well in the Texas Pediatric Society to create a similar, to look at a registry or to design a registry in the event of disaster. Certainly not as robust as what you're describing, but it strikes me that with all these independent efforts and with your successes, perhaps our next steps are to connect Dr. Hartstein to you and to look at the interplay between the chat initiatives and the Texas Pediatric Society.
happy to help.
Yeah. Just a couple of comments. Thank you, Sharon and Cameron, for being here. The brochure that you have, the full-page brochure, shows you what other cities in the Dallas-Fort Worth area are using the SNAP program. And as early as this, or late as this morning, there was a fire somewhere in the Metroplex where there was a man wheelchair-bound, unable to get out of his home, and he perished in the fire. So if there had been perhaps some kind of prior notification that that patient was in that house, he might not have had to die today. So.
Sam, anything to add to the state partnership report? Was that your final agenda item?
Yeah, that's all I had for the EMS for children, but I would like to also add to Sharon's talk as far as another group that would be important for that partnership is the Texas Parent to Parent organization that works with children of special needs. And this would be a great topic to present at their conference coming up in the spring. So I'll get with you later for that. So
it's a great idea. All right, thank you. So next agenda item, an update on pediatric transfer guidelines in our facility transport review.
Yay! I'm so excited. This is what I hope is the final version of the considerations for pediatric transfer and consultation. The work group that we had put together has reviewed this with almost no recommendations for change. So I hope that with just a tiny bit of tweaking it, if there's Dinah's already found a typo for me, we will be ready to approve this at this meeting and move it forward to the other subcommittees in February.
Great. So
the feedback's been very good.
Can we take a minute to, do you want to walk us through the document?
Well, I sent it out to everybody in advance, but sure, I can.
And I think we've also posted it. An original version of it. Okay.
Yeah, it's just been tweaked ever so slightly since then. One of the things that I did do was add some other criteria at the recommendation of Dr. Sainz in relation to child maltreatment. So at the bottom of page 3, you'll see other criteria. I changed the A example, injuries sustained, and it said that don't match the story or whatever it says now with no reported explanation. And then the last bullet there, upper extremity fractures in a non-ambulatory child, has been added just to give people examples of when to think child maltreatment. The other thing that has been added is on page, I think it's 6, 1, 2, 3, 4, 5, 6. Under method, there in the original draft, what we had was the Washington State definition of a specialty care transport team, and so I visited with Joe Schmieder, and he directed me to the Texas Administrative Code, Title 25, Part 1, Chapter 157, Subchapter B, Rule 157.11, and that is where the definition of specialty care transports resides in the rules, and so that information below that was lifted directly from the rules, so those definitions match the existing Texas Administrative Code. One thing that I did also take out, because someone had made a comment, we had, it was under types of transport. A BLS transport on page whatever that is it 7 or 8? Where it says stable with no risk for deterioration. We had basic life support and it said oxygen, monitoring of vital signs, and saline lock. And someone came to me and said that if a patient has a saline lock, that automatically bumps them up to an ALS unit. Is that true? No? Can a BLS unit transport a saline lock? Yes? No?
Depends on your protocols.
Oh,
I would say
okay.
If the medical director said that that's appropriate for that EMT level, then yes, that would be okay, but it would have to be addressed.
Okay.
So maybe you should put something per their protocol.
When they looked at it, they would question it. and they would want to see it specifically written in your protocol that that was acceptable.
So saline lock with medical director approval? Okay. Well, I'd like to put that back in there, and I'll do it if it's okay with that caveat. Okay. And then the last 2 pages are the children's hospitals in the state of Texas, their addresses and their contact information, and if they have a transport team, that transport team's direct line phone number. If there are hospitals that I'm missing, please let me know. I got most of these off the chat website, and then those that I knew of that were not chat members, I just went and Googled them and found their names and addresses and stuff. That list had previously said designated trauma centers. I took that out and just made it children's hospitals. So these are your resources for tertiary pediatric care. And if there's wrong numbers, wrong addresses, or anything, please let me know. Otherwise, I'd like to make a motion that we approve this guideline and move it forward in February for the other subcommittees to review and approve.
I second.
Anybody second? Great, thank you. All in favor?
Yep.
Aye. Anyone opposed? Any public comment related to the consideration for pediatric consultation and transfer document? Great, then we will bring this to the other committees. We'll let Big GETAC group know that we need endorsement in the February meeting. Is that correct?
Yeah, and we'll put it on the agenda for the other subcommittees in February.
So if you can send me the
Final?
most revised version, I will add that as an addendum to post that publicly
Okay.
to the minutes.
All right. I want to thank the task force that helped with this. Dr. Remick, Christine from Waco, Christine Reeve, Justin Boyd, Deb Boudreau from Cook, Dr. Moreover from Abilene, and Sarah Safront from Harlingen. I'm probably missing someone.
Can you reference those people?
Yes.
In the front page?
Yes.
Great, thank you. All right, very, very nice work, Sally.
Thank you.
All right, that moves us to our next agenda item, which is actually a combination of both 7 and 8, which is an update on clinical guidelines, evidence-based practice guidelines. I think the only, Dr. Shaw could not be here today, the only update was the active rollout of the Pegasus protocols in Houston. Otherwise, they're making steady progress across all guidelines. Anything to add to that, Sam?
Yeah, nothing to add on the Pegasus project, but on the EMS clinical guidelines, those, are y'all familiar with NASEMSO, the National Association of State EMS Officials? Okay. So those model EMS clinical guidelines have been completed, and they're now available for usage by all the medical directors across the country. And they do incorporate the evidence-based guidelines for across the board, adults and pediatrics. And as far as pediatrics are concerned, there is a large section in there having to do with pediatrics, and Dr. Shaw, as well as Dr. Remick, participated in that process as far as helping to develop these EMS guidelines. But they are available now on the NASEMSO website.
My notes indicate that they cover 40 different clinical situations, and the specific populations that address pediatrics, asthma, bronchiolitis, croup, pain management, seizure, shock, and seizure and shock.
And spinal care.
And I'm sorry, what was that?
Spinal care. So covers airway management, allergic reactions, asthma, bronchiolitis, croup, pain management, seizures, shock, including the control of external hemorrhage, and spinal care.
So for purposes of completeness in the meeting minutes, that website Do you have that?
It is nasemso, NASEMSO.org. And you can find it right off the homepage there.
Okay, perfect.
All right, thank you.
Thank you. That puts us at item number 9. Do we want to, Diana, do you want to roll in the discussion for data, since Jorge's not here to present the trauma data into the quality metrics and data in general?
Yes. So the quality metrics for the improvement, we haven't done much on yet because there's so many issues with actually statewide data on pediatric care. And that sort of dovetails into the registry discussion. So at the August meeting, we had both at the EMS for Children Advisory Council and then also at the GETAC meeting here, there was discussion about there were several children's hospitals and other Texas hospitals, trauma centers that are on the new DI platform called CV5 that does not have a state interface. And so as some of that injury prevention and Texas state data was presented, our region, in particular Region O, didn't have any of the Dell Children's Medical Center data because we've been on CV5 for over a year. Since that time, we have done, our vendor has assisted us in uploading our data through the old portal. We've also we know that there's other children's hospitals that are moving toward CV5, and part of that is being driven by TQIP. Now that that's a recommendation for pediatric trauma centers. So Dallas Children's and Cook are both moving to that. I don't have a good sense for the other children's hospitals and what platform they're on, so that's sort of a next step. And in talking to our vendor at Digital Innovations, they are telling us that it resides in the hands of the state. And so we need to have a conversation later after this meeting to sort of find out where are we with that process. Particularly, it's going to become more and more important as Cook and Dallas go live with CV5, because we want to make sure that we are capturing those places that are taking care of children. And then there are adult trauma centers that we know children are cared for there that are already on CV5. So if you haven't, as a center, if you haven't reached out to DI to help with the Texas state download, then Texas Registry doesn't have your information. So I know we've been circulating emails through the different groups and the different racks, and given those instructions after the August meeting. But again, it's sort of there's a lot of he said, she said and so any clarity that we could get from that would be awesome.
Great.
Now, do you have any?
Can we get Christopher, can you come and help?
Again, if we want to tie in this into...
Yeah, let's go ahead and do it with the next agenda item, which is the trauma registry report.
Can everyone hear me okay? Can you hear me now?
They can't.
Oh, it's not perfect. Hello. Okay, I can hear myself. Dr. Macias, thank you for the opportunity for us to speak on behalf of the Trauma Registry and to provide the Pediatrics Committee a update on where we are at the state. I got an agenda that I've been writing down over here for myself in regards to the topics that we talked about so far today. And so we'll just jump right in with Diana with where you're talking about facilities not being able to submit data to the registry. We do have an update that we can provide to the committee. To my left is Rob Klein. Rob Klein is our project manager. And just for sake to introduce myself, I'm Dr. Christopher Drucker. I'm the new manager of the Injury Epidemiology Surveillance Branch, which oversees the EMS Trauma Registry. And so, Rob, will you be able to give an update on where we are with our latest build?
Yes. Thank you, Chris. So we've been really working diligently to get this, I guess it's this XML upload, because DI and all the new vendors are moving to XML, and we understand the urgency in this. To give you an update, we were hoping to have this this new release out this week. This is how close we are. We ran into one little issue. It's not with that we cannot receive files, but we have a very new extensive feedback report that when you do upload, it will give you all your errors, your warnings, and also tie it back into how many incomplete questions were not answered. We have built it all on the new National Trauma Data Bank data set, 2014, and so we have all those changes ready to go. We are just doing a final testing, and I expect this, we'll have this release out within the next 2 weeks. So that's our push. We've been working very hard. We were hoping to have this actually out about a week ago, but we ran into some little technical issues on our internal systems. But we're working with our vendor, and we've kind of identified the areas, and we should have that. We're going through our final testing right now.
So can I ask a question?
Sure.
Or a favor, actually?
Yes.
So I think it would be very helpful for communication to come out to the trauma centers.
Yes.
About this, rather than us continue to sort of communicate amongst each other and DI on where we are, which just adds to frustration because we spend a lot of time collecting a lot of great data, and obviously we want to share that.
Correct. One thing that the program is going to start doing is anytime we come out with a new release and we put it into production, we will be holding, first we'll email everyone who has an email account within the registry to let them know what the new changes are. And then sometimes just on paper you may not understand it. So we're also going to hold webinars maybe about a week afterwards of the new release where the state will be able to go through each of the new additions that were just placed in production. So for this case, when this new release goes into production in the next week or two, we'll hold a webinar afterwards, and we'll talk about the submission feedback report. We'll talk about the ability for those who have data and need to submit it through XML upload, how this is going to be it's in that new build, and then this is the process from there. So we will be doing a more complete job in communicating with stakeholders and with entities on whatever the registry has now newly implemented.
If I can make a suggestion, when you send out that new release, that you also put an FAQ or something that's sort of, because we will start using those data fields, so to wait a week to do a webinar might not be the best plan.
Well, the registry right now, we also implemented an FAQ, and it's a living document, meaning that we're not going to cut it off. So whenever we start seeing questions that are starting to pop up, we will go ahead and post that question up to the FAQ, and then we will provide a response onto that. Okay. So there's a lot of new things that the registry that we're trying to do. We really are moving forward, and it's going to be quite an exciting time now, not even in the future, now. And so we'll be able to communicate that with you. Any other questions in regards to the XML upload or anything related to the new build that's coming out into production in the next couple of weeks? If not, I got a couple other items, Dr. Maciel, I'd like to address. Going back to Amy Bailey on the child fatality review, one of my staff epidemiologists will be serving on that work group, that drowning work group at the state level. I just want to remind the members of the committee that although it does sound like a great idea to have a one-stop shop for all submersion events, the data that is collected in the EMS Trauma Registry is data that is legislatively mandated. And by rule, under Texas Administrative Code, Title 25, Part 1, Chapter 103, Section 103.4, it indicates which entities are mandated to report to the EMS Trauma Registry. And in regards to submersion events, that is justice of the peace, medical examiners, physicians, and hospitals. And so we get submersion events from these entities. And so we, at this time, according to the way the rule is written, we will not be able to put into the registry, for example, a submersion event that comes from Parks and Recs or something like that. And it has to come to one of these 4 entities that is by rule. And so it does sound like a great idea to have a one-stop shop for all submersion events.
So can you just clarify that? So the way the rules are currently written, it provides exclusion of other areas, or it simply doesn't include other sources?
The way the rule is written right now, it indicates who should be reporting to the EMS trauma registry.
But it doesn't say who should not.
It doesn't say those are not excluded, but it does say those who are included to submit data.
So,
for example, we also have submersion events from local and regional health departments, and so we met with our legal to determine, are we allowed to collect this data? And in short, without giving you the whole legal description, the answer was yes. And so, and the way it's done is it's as if it's a pass-through. So your local JPs or MEs, physicians, hospitals submit it to the health department, and the health department submitted it up to the registry.
So I think the bigger issue is we're trying to work backwards from what is a usable data set that gives a good cross-section of what the state of drowning injuries are for children in the state. So if I needed to work backwards, what I'm hearing is that you're saying these rules dictate that there must the existence essentially of these disparate data sources.
Correct.
Is that correct?
So does the rule preclude from incorporating the submersion data set into the trauma registry?
Say that again, Diana?
So does the rule preclude having the submersion data sets incorporated into the state trauma registry?
So external.
So that we are, for those of us that are doing both of those registries, so that we're doing one registry rather than two separate. That's what I was alluding to before,
Okay.
is that if you're going to build a data set, why not use a very data-enriched data set and just add it to, rather than creating another separate event? Does that make sense?
I'm trying to capture who's, in this case, will be submitting the data.
So I'll use our example. So at Dell Children's today, we have someone who's doing the drowning registry, totally separate outside of the trauma registry. The trauma registry may incorporate some of those patients that were in a drowning registry, but so now you're duplicating work. So it's not very efficient. So as we continue to put more and more data into the registry, for TQIP and other reasons, it would sure be nice if we're doing the work into one spot rather than we've got different questions that we have to ask for the drowning, and we have different data set for trauma. So why can't those be incorporated in together?
Rob Klein will answer that question.
We can look into that, and yes, we probably can tie those together. We get all our drowning information basically through our National Trauma Data Bank set, our data set there. So we could actually expand that and make the submersion piece, since you're going to give us some Texas custom questions, and tie what we have in submersion now back in so the two can be sent all at once. And that's what our goal is.
Okay.
So we have looked at that. We've had some other entities ask us for the same type of thing. So now we're taking a look at that. And we have actually put that, I'll talk more about this in a minute, but we are putting a business case together for our fiscal year 16 and 17 that will include exactly this.
Okay.
So I'm going to put you on the February agenda to update the group on progress in consolidating submission to single. Was that?
We'll be able to give an update in the February GTAC. I also wanted to bring to the attention to the committee, in the last GTAC, I got up to the microphone and I spoke about a report that the program has put together. So I'm not going to go through the report, but I just wanted to mention again. We understand that there are some large entities out there who are unable to submit data to the registry. And once that data starts coming in, earliest in the next week or two, the state is at a point now where we can start producing reports. And with that being said, we are looking to work with the respective communities to generate such reports. And so on our website, we currently have this EMS Trauma Registry 2013 Pediatric Summary Report. This report is dated kind of early in the year, it's back in August, and the reason why we haven't updated it is because, one, we're looking to get feedback as to what may benefit the pediatric community in a statewide report, and two, because of the inability for certain facilities to submit data, certain children's facilities. And so once all that comes in, then we'll be able to put together reports. But for example, just as a first-time pediatric report, we went ahead and we created a report that looked at pediatrics in an EMS data set, pediatrics in the hospitalizations, and then the pediatrics in our submersions. And so this is a 36-page report that breaks down these different components, looking at pediatric runs. I personally did pediatric runs for EMS. And to just give some overall statistics of the type of data that comes in for pediatrics. And so I want to encourage those in the pediatric community to go through this report, to look to see what the data is suggesting. Understand that we will be creating an updated version once we get all those facilities are unable to submit data now, but to talk with us so we can start creating these reports that will benefit the community.
When you say an updated report, you mean updating the numbers or adding additional variables?
Both. Updating the numbers, but then to also sit down and work with the communities to devise some type of annual report to include specific metrics in which we may not have knowledge of that may be beneficial to the community.
Just checking to see if you're awake.
So, Chris, if I can ask a question. Going back to creating reports. So, in theory, we could use some of our performance measures that we want to try to track through the EMS for Children grant. And if we could somehow incorporate that as sort of a benchmark report from the state, it'll give us a global view.
And that's what I'm asking for. That's a perfect beginning step to working with the data we have and creating something that can be useful to benchmark the data we have in the state for whatever purposes that your individual facility, your region, or the state may have as a whole.
So, and there would be a way for you to break out children that are seen at non-pediatric facilities?
Yes, we'll be able to break that out. There is a degree of specificity that we can't go down to, but at the macro level, we can look at that. So we won't be able to say these results are based from this specific pediatric facility, but we can look at it as a large scale and produce reports such as
Yeah, I think the cluster would essentially be 8 children's hospitals versus all others.
Right.
Yeah, right.
I'm thinking of the PEDS readiness information, if there's ways that we can.
Yeah, absolutely. So I think, what if we did this as a next step? So this is a PDF, correct? So we could annotate with sticky notes. If you send this to me, I'll disseminate it to the group, plus to our the EMSC Advisory Committee. We'll ask for their input into integrating the metrics that we want to collect there. There's also some additional metrics that EMSC federally has created as a scorecard that we'd like to integrate as well. And then we'd like an opportunity to look at these and understand whether some of these are clinically relevant, and if there are other areas that might be clinically relevant that we'd sort of like to have as a wish list. Would that be reasonable?
This report's from August, though, correct?
This
is the one that's on the website today?
This is correct. This is the one that's currently on the website. It's data as of August 5th, 2014 for 2013 records submitted. Correct.
Can that be updated to include the information that Dell Children's dumped in August for all of 2013, almost of 2013?
Correct. So this report this generic report that we created right now will be updated. Will not be updated till the end of the year when we start getting those facilities that are unable to submit data to us. And then we could work with the committee to determine the time frame in which preliminary reports will be useful, and then when we can finalize such reports.
So before January 1st, you'll have this updated report. You could forward that to our group. That gives us roughly 5 weeks to comment on it.
Yeah, that would actually, so an updated report would be the most helpful, because that'll capture whoever may not have been able to submit before that now can. And then at our February meeting, so even at the EMS for Children Advisory Council, we could digest some of that. It would give us time to sort of digest the report and then come up with some true metrics of what we want. We can discuss that in the February meeting, so that the goal would be that we have a benchmark report by the August meeting.
Well, is there any chance this would be done by December 15th? The update?
The update, given our current staffing and the other reports we're working on, I'm afraid it will be highly unlikely that will be available by December 15th. But I can check with my staff to see what their availability looks like.
We have a 4-hour work session
Yeah.
where we're combing through the strategic plan, and we could tack this on as an agenda item.
Okay.
And actually, we could probably even have him come.
Oh yeah, it's in Austin.
Because it's in Austin. It's at Dell.
Is that Dell?
Yeah.
Okay. Yeah, we'll love to come on by and to really work with you to move this forward. Okay. And the last thing that I have on my makeshift agenda is talk about our business case. Every 2 years, we have to produce a business case which goes on up to our executive leadership. And this was put in for FY16, FY17, and Rob will talk about the business case and specifically how this committee can be integral in that business case.
So it's kind of an arduous process, but at the Department of State Health Services, we have to put together basically we put together a 2-year business case based on the biennium. So the business case we're working on now will affect fiscal year 16 and 17, which would start September 1st, 2015. In the business case, it was interesting that of the speakers to point, because 2 areas in the business case we've already identified is, first of all, linking the submersion data to improve the collection of risk factors and information for prevention planning. So that was one of the key things we had actually put in the business case. So it kind of ties into this whole submersion and trying to fix this data collection process. So we were working towards that already. This is going to help put funding in for that to make sure it happens. So I was very pleased that this is a hot topic with that, and we understand that. The other key thing is, as we move forward in looking at the pediatric and adolescent report that Chris here has put together and your committee now wants to take a look at on the 15th, another key item that we have is we want to continue this broad-based pediatric adolescent reporting. We have that, we'll also put that into our fiscal year 16 and 17 plans, because we want to get the data out so that if we have any revision to protocols, triage, or injury system planning, that can also help there too. So we really have got 2 areas here that you've kind of got hot topics that we already have built into our business case. And right now, leadership has kind of given us a go-ahead. We haven't got the final sign-off yet, but for funding for this will be signed off by executive leadership in the next 2 weeks, and then that'll go to the legislature for actual approval. And we should see approval before this year-end fiscal year, and so we can kick it off for the for fiscal year 16 and 17. And then part of this process that we have to do every year, which also makes it, we have to find funding for this. We have usually get funding through TxDOT, through the NHTSA program for highway safety and motor vehicle crashes and those type of things. So we are working with TxDOT to help fund a number of these areas here, and we would put in forward to get a grant from them to help push this forward. So they're still indicating they're a willing partner in this. They've helped us fund a lot of the work we've done to date. But there are a number of moving parts in putting this whole thing together. So, but we're looking forward, and we've got a good plan for the next 2 years.
Thank you. We'll send you that invitation to the December 15th meeting.
Thank you very much.
All right. Next agenda item is the GETAC strategic plan update. In our last meeting, we identified additional domains that we thought were important: rehab, special populations, community outreach, equipment, resources, geographical challenges, performance improvement, and patient safety, preparedness, professional education, sustainable funding, reimbursement, system access, system leadership, and workforce issues. We also described as sort of a more global attention to quality and quality improvement. From what we have done, recognizing that our real work is going to be on December 15th, are there any general areas that we need to address? Is there anything that we need to prepare for to migrate specific elements in? For example, like quality metrics, that sort of thing. Okay, then we can just bring what we need to the December 15th meeting. I inadvertently left one agenda item off, which, since I did not post it on the agenda, we'll have to table, and I'll make certain it goes on the February agenda, and that is paramedicine scope for pediatrics. That was, Charles, that was yours. I apologize for that, and I believe Sam was going to help inform some of that discussion based on current EMSC work that was being done, I believe, for asthma in particular. So look for that on the February agenda. Other than that, I believe we are now open for general public comment.
If I could make some suggestions for the strategic plan.
Yep.
One suggestion would be disaster preparedness, the incorporation of pediatrics into disaster preparedness, and to see how well we are incorporating that into our EMTFs and that type of thing here in the state.
So I think this ties nicely with what we've just heard about SNAP. It sure would be nice to have a goal and aim set into the strategic plan around children with special needs.
It may be even worth at the excuse me, at the February meeting, having Victor Wells or Eric Epley or both of them come and present to the PEDS committee just exactly what they are doing to incorporate pediatrics into the disaster plan within the state, because I don't personally have any idea what's going on. I don't know if you all do either, but I'd be interested in learning more about that and how we can help them out with that.
So our disaster preparedness liaison is Bonnie. We can ask Bonnie to work with the committee.
Okay.
They meet right before us, so that might work out.
And then just one other area that is, I've heard spoken about at previous GTACs and is happening on the national level, is the integration of military paramedics back into the civilian world. As far as on the pediatric side, my curiosity is how the military bases here in Texas, because we have a bunch, are taking care of kids, not just the military EMS, but also their hospitals. because there are several military hospitals, and both of those, the EMS agencies and the hospitals, were left out of the National Pediatric Readiness Project and the EMS assessment. I think that on the national level, that was just an oversight on their part. And I don't know how that fits into the strategic plan, but I recently spoke with, her name is Master Sergeant Heather Yates. She is the EMS director for the United States Air Force, and she's actually based out of Lackland Air Force Base here in Texas. And she is willing to work with us, EMS for Children, to perform the same EMS assessment Air Force-wide that we conducted for our agencies here in Texas. And she also knows the EMS director for the United States Army, and I haven't had an opportunity to speak with him yet, but if we had the potential to do that with the Air Force and the Army, I think that would, to my knowledge, be the first one in the country that actually saw what the pediatric capabilities of our military EMS agencies are. So, and I'd like to do something similar with the military hospitals. That might be a little bit bigger project, but
But you're talking on the state level, correct?
I am talking on the state level, yes. But we could branch it out to nationwide as well.
Well, it just
I know.
means an integration with EMSC federal.
I know.
Which is, I'm sure they'd be open to it.
So that's just a couple of my suggestions.
Okay.
And to keep the mobile integrated healthcare on the radar.
So you're going to take this Air Force and Army assessment component through EAC? Is that the next step?
Yes.
Okay.
Yes. Now, obviously, that while she's in favor of that, if you're familiar with how the military works, she still has to kind of run that up her chain of command, but she doesn't foresee an issue with that. So,
great.
All right. Thank you.
Any other public comments?
Christine Reeves with Hot Rack out of Waco. One thing is I enjoyed the SNAP program presentation. I do caution that a lot of us are using the STEER program to do the same thing, and there's got to be some way to get, and it's concerning that there's even another entity looking for another registry to register special needs children and others. So that's, 3 registries, and they won't know which one is the right one to register in to make sure they don't get left out of the loop. So the more registries we have to register our special needs populations, the more of a chance we're going to lose them than we're going to lose them right now when they're not registered. So we need to do something about that. I'm not talking about trauma registry and submersion registry. I'm talking about them letting us know they have a ventilated kid, they have whatever the case is.
And I think that is actually what started the discussion from the onset, was Dr. Hartstein investigating the relationship with STEER, what its catchment looked like, what kind of access was available, and then trying to understand how often that was updated. And I think that was the burning platform, was that there were names in there for people who hadn't existed in those geographic regions for years.
Right, but the information's there and it's already built, right, and so it's maintained by somebody who has the ability to maintain it without us having to find the money. And a lot of us are going back in our regions. I serve 3 trauma service areas for disaster preparedness, and we have got with public health in our hospitals about getting the STEER updated and working with the local emergency management offices who have access to that and working to get the data clean. So I just want to make sure everybody's on the same page moving forward. We were connected several years ago between the pediatric community and the disaster preparedness, and we've kind of lost that connection. And so whatever we need to do, I'm not sure just one representative is enough to keep that connection together.
Yeah, I think investigating what best practices and what the communication needs to look like, because I currently have, you described 3, but I've got STEER, CHAT, Texas Pediatric Society, Texas Parent to Parent, SNAP, and that's really
right. That's a lot.
Yeah.
So just 2 cents on the preparedness piece, and then the other is just to kind of keep that perinatal maternal designation thing kind of on y'all's radar, because there are a lot of things being discussed that might not be in the normal flow of how patients flow now for other types of issues. Just, I've been attending several of the meetings. And so some of them are kind of out on their own and don't really care about what the current practices are about movement of infants and neonates.
It seems to me that we could probably have somebody come in February.
That would probably be
talk to
great.
us. I don't know those group members.
I do.
Who would you recommend?
Well, Dr. Toy, that
Dr.
is
Toy
in
would be
Houston, is the chair of that group. And one of our former NI directors at Cook is sitting on that committee. She and I have talked quite a bit, and Rick and I had a conversation with Dr. Toy about the advantages of aligning with the RACs in terms of infrastructure and all that. So I know that they still haven't finally decided how they will align, and there are several people on that advisory committee that want more information from the RACs about what that looks like.
Even if it's not the RACs in public health, there's still a piece. I mean, I'm not really speaking as a RAC on this piece. It's just more about better for the patient population. But, you know, not the same groups aren't aware that things are already in place.
Mhm.
But I think Dr. Toy would definitely be willing to come speak. He's very open with thought processes and where they're going. And if there's this group has a different thought process, he's definitely open to those things, but he does need to hear from different areas.
Yeah, he was very open when we talked to him about it.
Well, do we know if there's an Austin resident on that committee, since our next meeting's in Austin?
I don't. Do you, Christine, who from Austin? I could find out.
Yeah, I can look. I'm pretty sure there is.
Yeah.
We could probably ask Jane.
Yeah.
I saw her earlier, but she's not in here. Oh, she's over there. But she would know. I think there's several Austin.
Dr. Cho is from St. David's.
That's right, Dr. Cho.
Dr. Cho?
Yeah.
CHO?
Yes, sir.
Thank you.
Thanks.
One last thing, Charles. I knew I was forgetting to thank someone when I talked about my work team, and it was Julie. Thanks, Julie.
All right. Any other public comment? So we've hit all our agenda items. Our next meeting for the Pediatric Subcommittee is December 15th. Thank you for your participation. We are concluding with 4 minutes to spare.